So we gather today experienced specialist experts and members of patients association and organizations. So I'm glad to welcome representatives from South and Southeast European countries and Visegrad Group. Ladies and gentlemen, good morning or good day, whatever. I welcome ladies and gentlemen from Albania, Bosnia and Herzegovina, Bulgaria, Czech Republic, Cyprus, Croatia, Kosovo, Georgia, Montenegro, North Macedonia, Romania, Serbia, Slovakia, and Slovenia. And now we are going far, far away and a long distance from Croatia. We are going to the United States of America. The star and moderator of this part of our event or session is founder and managing director at the Center for Disease Analysis Foundation, Mr. Homi Razavi. Homi, are you awake?
Yeah, I'm awake. Thank you so much, Anna.
Okay, Homi, let's roll.
Wonderful. Well, thank you very much for the organizers for the invitation to be here, and fantastic job on bringing this group together during the epidemic, the COVID-19 epidemic. As you all know, there's incredible amount of diversity in the region with regards to where we are in terms of the hepatitis elimination. So if you look at Romania, and this is on the Polaris website, this is all publicly available, we have 6 deaths per day as a result of HCV infections and 8 deaths per day for Hep B. So there's 14 deaths each single day in Romania as a result of HCV and HPV infections. Now, that's one extreme, and I'm going to show you Georgia in a minute. Now, we want to recognize everything that Romania has done. So incredible. If you look at the targets, the WHO targets, very nice job on blood safety and injection safety. This is medical injection, but what you see for hepatitis is there's simply not diagnosing and treating and harm reduction for the PWAC. Now, on the hepatitis B side, of course, Romania has an amazing job in terms of HPV 3-dose vaccination, but birth dose vaccination is still about 36. If we look at where Romania is, the Romania is not going to achieve any of the WHO elimination targets till past 2051. But on the hepatitis B side, in fact, Romania has already achieved prevalence of 0.1% in 5-year-olds. So we want to recognize the fact that has already been achieved. But for diagnosis, treatment, and mortality in Hep B, we're not going to get that. So that's one extreme. Now, the other end of the extreme is really Georgia, as we all know, have done a pretty amazing job on running the hepatitis program there, hepatitis C. So the number of deaths are 3 per week for Hep C and 5 deaths per week for hepatitis B. And if we compare the graphs, again, what they've done is an amazing job in terms of screening and treatment. But one of the shortcomings is the syringes per PWAC. So this is based on public information. And if we look at when Georgia is going to achieve it, and of course for hepatitis C, they're going to hit the diagnosed, treated, and mortality before 2030, the only shortcoming is the reduction in incidence. But on the hepatitis B side, very similar to other countries, very little being done in terms of diagnosis and treatment. And so that's going to be post 2050 before we achieve that. We have an amazing group of experts that are going to actually describe what's going on in individual countries and explain why we're stuck in this part. And it is my pleasure to introduce Dr. Vince again, who's going to describe the Croatian pathway. I'm going to turn it over to you, please.
I'm going to try to present in short our plan or how we came to plan drafting. So just a few technical seconds. Okay. So what happened in Croatia regarding action plan for viral hepatitis? As I mentioned before, action plan, why do we need action plan? Because that means we made comprehensive planning based on the national epidemiologic and health circumstances. So it includes always short-term goals and long-term goals, according to WHO. It includes activities. The country has to provide indicators. It includes responsible groups, monitoring and evaluation. We all are not very keen on doing monitoring and evaluation, but the action plan forces you to do so. And of course, very importantly, it includes financial framework. So when you do all this by writing your action plan, you are actually strengthening your epidemiologic surveillance system, which is very, very important. So, Croatia, where was Croatia in 2016 when WHO started the whole process? So we had a good tradition in epidemiological control of infectious diseases, what we have shown also now with COVID-19. We had national guidelines already written for the third time for diagnostics and treatment of viral hepatitis. We have developed network of NGOs and patient association, as you can see here. We had already harm reduction programs in place for several years, OST, needle exchange. And also in 2016, direct antiviral therapy already available, but priority were patients with F4. So at that time, we had all of those segments, so to speak, but no comprehensive action plan in place. So what did we do afterwards? So in 2017, we met together, the expert, and we started analyzing the baseline data on epidemiology and disease burden for viral hepatitis. And at the same time, we started lobbying at the Ministry of Health, of course, to get somehow things going with the National Action Plan. So people who were most important stakeholders who were really strongly involved from the start were infectious disease specialists, also our colleagues, gastroenterologists, national public health specialists, epidemiologists, our WHO country officer, she helped a lot, and patients association. Without them, we couldn't be starting at all. And also, I have to mention, we had from the start a huge support from Croatian Insurance Health Fund, their medical officers, who realized how the therapy was efficacious, and they made a kind of system where they only paid for performance principle. And they saw that 97, 98 patients can be cured. They never ever have seen such a good therapy for any other disease. So they were really convinced they were doing a good job by making this therapy possible for the patients. So we had a working group, so you can see coordinational body as WHO has suggested. How to do this planning, and we all worked together and called other stakeholders in when we needed their opinion as well. So what did we found actually during the situational analysis? We found that there is underreporting of new cases of hepatitis, that there is insufficient testing for HCV in populations at risk, poor education, this is very important, poor education of health workers on risk factors. Many of our doctors still don't ask their patients whether they have received blood or blood products before 1993. And also what we found looking at the hospital medical records, that cirrhosis and hepatocellular carcinoma, those patients are not being checked for viral hepatitis markers. And then we realized that we have still ongoing epidemics in people who inject drugs. Okay, so steps in formulating the action plan in Croatia whereas you can see in 2018, Ministry of Health, after doing all this baseline job, Ministry of Health formed this working group consisting of various experts dedicated to viral hepatitis. This was in the beginning of 2018. We collected systematically epidemiologic and disease burden data. We looked for additional expertise from different stakeholders when we needed it. And working group developed the National Action Plan draft through February 2019, which was shown and presented to the Minister of Health. And then this draft was sent back to stakeholders to receive their final confirmation. What was planned for the future, e-consultation of the final draft, and finally endorsement by government. So just to tell you a few goals, which actually are the most important goals of comprehensive action plan. First one, and I think the most important one, is about raising the awareness in general population and key population, and also a short-term goal is raising the awareness in healthcare workers. Long-term goal 2 is monitor health sector response, that we monitor screening programs, etc., etc. Long-term goal 3 is reduce new infections. Long-term goal 4, we also to sustain the epidemiologic control of hepatitis A, because we had epidemics in Europe as well a year ago. And long-term goal 5 is reduce the mortality for 65%. So what were the recent developments? Working group developed the action plan. There is a draft from February 2019. It was, as I already mentioned, sent to stakeholders for their feedback. And so just we had the changing of the Ministry of Health, January 2020. We still did not get the feedback from all of the stakeholders at that time. And as you all know, we had COVID-19 that came in February. And we had the first patient at my department that come from Italy to Croatia at the 25th of February. And the last patient was discharged just a few days ago. So what about the National Action Plan? It still waits for the endorsement, and I have to say that Croatia still does not have an active action plan in place. Okay, thank you. So just the basic steps, I would say, are important when you plan to create national plan: situational analysis of the existing data, presentation of the data to the health administration, then presentation of the possible solution to the administration, and presentation of the financing with the accent on the therapy efficacy as we have today. Okay. Thank you. And just to say at the end, this is the place where I work. You can see this is the department with balcony units. Here we also have isolation unit, and here is actually also the place where we have treated hundreds of patients with COVID this year. Thank you.
Thank you very much, Dr. Vinter. That was really impressive progress in Croatia. Now, for those of you who are familiar with the work in the region, of course, Professor Matchett in Slovenia has been a lot of work in microelimination. And it's a great honor to introduce her to describe microelimination and the work that they're doing in Slovenia. I'm going to turn it over to you, please.
Ladies and gentlemen, it's a great honor and privilege to participate at such a high-level event, and I'd like to thank the organizers for inviting me to present the activities of my country, Slovenia. However, being an infectious disease specialist, during the past 3 months I was heavily involved in the national management of COVID-19 epidemic in Slovenia, and even though by the end of May Slovenia has become an epidemic-free country, My current and ongoing intense obligations still prevent me to be there with you, which I heavily regret. So allow me now, for that reason, to virtually present you the activities and the model of Slovenia towards the microelimination of hepatitis C, which is specific exactly for this microelimination approach. In 2015, within a 2 million population of Slovenia, the prevalence of hepatitis C virus infection was estimated at 0.3%. A huge national study has shown that 2/3 of currently infected reported IV drug use as the mode of infection. But luckily enough, 23 years ago, Slovenia set up a national policy for HIV management. Way back in the year 1997, the Special Interdisciplinary Viral Hepatitis Expert Board, of a group of various experts and professionals that were highly involved in the management of viral hepatitis, set up the first national strategy for the management of hepatitis C. And this strategy also involved all the procedures of the cascade of care, including awareness and testing campaigns to be positioned within a routine healthcare service. That means that they were also supported and financed accordingly. Luckily enough, historically, Slovenia also had all the currently recommended treatment of care on time, including all the direct-acting antivirals. In Slovenia, there are 5 centers for treatment of hepatitis C being spread widely around the country. And since 1997, treatment for hepatitis C has been available and accessible for everybody in need. However, it has to be prescribed by nominated specialists, particularly infectologists, and according to the national guidelines, which have been regularly updated. Since 1997, there's also a national register of all the treated patients for hepatitis C in Slovenia. The complete treatment for hepatitis C has been covered by the national health insurance system with no restrictions except for a very short 2-year period between 2015 and 2017 due to high financial burden of the new direct-acting antivirals. Treatment for hepatitis C has been systematically followed up and analyzed on the national level since the beginning of the 19th, and the recent real-life study has shown very, very good efficacy of the direct-acting antivirals. These are the real-life data. So the model projection has clearly shown that by using direct-acting antivirals only and by reasonably increasing the diagnosis and treatment rates in Slovenia, the HCV elimination according to the WHO standards seemed feasible by the year 2030. However, by the end of 2017, there were no more restrictions for the use of direct-acting antivirals in Slovenia, so Slovenia decided to speed up the elimination process by using a so-called microelimination approach. What is a microelimination? Actually, this is the most pragmatic approach toward global elimination of hepatitis C, which means to break down national elimination goals into smaller goals for individual population segments for which treatment and prevention interventions can be delivered more quickly and efficiently using targeted methods. This means that microelimination became feasible in certain high-risk populations, such as patients with advanced liver disease, hemophilia patients, prisoners, children, and many others. So countries should just start microelimination for at least one group by rightly prioritizing people with advanced liver disease. In Slovenia, it was very clear by that time that the seroprevalence in selected groups was much higher compared to general population. So what we did at the end of 2017 is that we performed an active search for all the individuals belonging to a selected high-risk groups of patients through the registers, database, and so on. In all these individual selected groups, we tested all the individuals who haven't so far been tested or successfully cured for hepatitis C, and all those who tested HCV RNA positive got immediate treatment for hepatitis C with directly acting antiviral drugs. In that way, we very quickly managed to reach the elimination of hepatitis C in the group of decompensated cirrhotics, in those that were transplant patients. We also managed to do, perhaps the first in the world, the complete elimination of HCV infection within hemophiliacs. Why was that possible? Because hemophiliacs in Slovenia are systematically managed since the year 1967, and they were all screened for HCV infection in the mid-90s. So, by the use of microelimination approach, we just checked the register of hemophiliacs in Slovenia, picked up those who haven't been treated successfully so far, actively invited them to the infectologist, and gave them immediate treatment with direct-acting antivirals. And in that way, in 2018, microelimination of hepatitis C in the group of hemophiliacs was completed. It was true also for the patients on chemodialysis. In the recent years, there was a really low prevalence of HCV infection in chemodialysis units in Slovenia. However, in 2017, we interfered within the national guidelines for all the nephrology patients who got immediate HCV testing at the first visit at nephrology specialist, and in case of HCV RNA positivity, they were treated immediately with direct-acting antivirals. What about co-infected with HIV? Slovenia is really the lucky ones, because historically in Slovenia there was really a very low prevalence of HIV co-infected, 6.6%. However, in the last decade, this prevalence has been increasing, particularly in the community of men who have sex with men. So we introduced a regular HCV testing within this community, and we treated immediately all with acute HCV infection, and in that way we managed to reach the microelimination of HCV infection in this group of patients, which is of course a dynamic process. What about people who inject drugs? It is well known that in Slovenia the vast majority of drug users are managed in some kind of projects or programs. More than 60% are managed in opiate substitution treatment programs. These programs were developed in kind of a network of 18 centers in the mid-90s, offering also HCV testing. So in 2007, these 18 centers for treatment and prevention of drug addiction integrated with 5 centers for treatment of viral hepatitis into a network for the very effective management of hepatitis C in drug users. And the outcome was that merely 2 years after its implementation, the treatment rate for hepatitis C increased by more than 4 times, and the success was really amazing, 82% of sustained virological response. Keep in mind this was PEG interferon and ribavirin treatment. However, with the advent of direct-acting antivirals, of course, they were used also for people who inject drugs, and the real-life study has shown that the efficacy of direct-acting antivirals in people who inject drugs was exactly the same as the efficacy in those who were not drug users. So again, the modeling study has shown that by using direct-acting antivirals and by doubling the treatment rate in this group on opiate substitution treatment, in Slovenia, elimination of hepatitis C in this group of drug users can be achieved by 2026. But some drug users are also not included in opiate substitution treatment. They use, for example, low threshold settings, such as needle and syringe exchange programs and homeless shelters. And the study has shown that the prevalence of HCV infection in those groups is quite high. So the plan for the year 2020 was that we introduce mobile outreach units offering testing, FibroScan, as well as linkage to care in these low threshold settings. In that way, improve very much the cure of hepatitis C in this group. The same was true for the prisons, for incarcerated persons, because the plan for the year 2020 was to increase testing and treatment on stop, because prisons seem a very feasible location for microelimination. However, at the beginning of 2020, the COVID pandemic posed a huge and immense challenge to healthcare system within affected community, also in Slovenia. So we, of course, decided to follow the EASL ECMID recommendations for the management of patients with liver disease. And of course, we adjusted them for the national particularities and our feasibility. However, we decided that all the plans and all the activities towards elimination of viral hepatitis C for the year 2020 are put on hold, but not for more than 6 months if possible. Taking together all the results presented, by January 2020, the guesstimated prevalence of HCV in Slovenia was shown to be around 0.2%. This means that 82% of all the infected have already been diagnosed, and 54% of all the infected have so far been cured. There are still around 2,000 estimated HCV RNA positives who need to get management for HCV infection, roughly around 800 to be diagnosed and the rest to be linked to care or treated and cured. So to conclude, ladies and gentlemen, microelimination is a strategic approach which can contribute to elimination of hepatitis C. It is feasible in certain high-risk populations. As for Slovenia, I hope I persuaded you that it has a potential to eliminate hepatitis C virus infection as a public health problem before 2030, because microelimination has been completed in most of the high-risk groups. However, an increase in identifying the infected and linkage to care is still needed, so cooperation between medical services and non-medical organizations is crucial. And in these times, we need to try to minimize the impact of COVID-19 epidemic on HCV elimination. Thank you very much. At the end, I wish you a successful meeting, a fruitful discussion, and all the best in the future months, COVID-free months. Goodbye.
Well, thank you very much. So we're going to keep the questions until the very end. I'm going to turn it over now to Dr. Simonova, who will describe the current conditions in Bulgaria.
Good afternoon, ladies and gentlemen. It's a pleasure for me to be part of this meeting, and I'd like to thank the organizers for inviting me to speak here today. Just very briefly to present you where currently stands Bulgaria on the road towards elimination of viral hepatitis. I will start with some basic epidemiological data about the infections. The prevalence of hepatitis C infection in Bulgaria is 1.2%, with total number of 92,000 persons with active infection. The incidence of hepatitis C infections is quite stable in the last 15 years. There are two main routes of transmission of hepatitis C infection, and these are nosocomial transmission, which was the main route in the past, and injection drug use, which appeared very strongly in the early 90s and until now is the major driving force behind HCV epidemic in the country. The prevalence of hepatitis B infection in Bulgaria is 3.8%. Universal vaccination for all newborn was implemented in 1992 in the country. We also have routine 3-dose vaccination for Hep B for all children until first year of age. And according to the recent data for 2018, 96% is the coverage for bullet dose vaccination and 85% of 3-dose vaccination. Due to this universal and active vaccination policy, the incidence of hepatitis B infection in the country decreased significantly, and so the prevalence of the infection from 8% prevalence in 1992 to 3.8% in year 2000. Unfortunately, I cannot present you more recent data on hepatitis B or hepatitis C prevalence because such data are not available in Bulgaria. Hepatitis B and hepatitis C infection are the major risk factors for the development of hepatocellular carcinoma in Bulgaria, and the second major risk factor for the development of liver cirrhosis. And there are several studies which are proving that. On that side, you can see the result from the study on the proportion of cirrhosis and hepatocellular carcinoma attributable to hepatitis C and hepatitis B infection that we conducted in our clinical center in Sofia as a part of European pilot study. We found out that the hepatitis B infection was the reason for HCC development in 37% of the cases, and hepatitis C infection was the reason for HCC in 25% of the cases. Both viruses were the reason for liver cirrhosis development in more than 30% of the cases. Although it's quite clear that infections with hepatitis C and hepatitis B represent significant health problem for the population in Bulgaria, as well as significant burden for the healthcare system, we still don't have a national plan or strategy for viral hepatitis elimination. Our national plan is actually in preparation since 2017, but it is still not finalized. And on the slide, you can see a draft from that. Now, I would like briefly to comment on the recommended by WHO key interventions towards elimination and how we are progressing on it. We have covered the targets for 2030 in respect of HBV vaccination, as well as for the safe injection in healthcare facilities. However, three other areas remain problematic in Bulgaria, and these are harm reduction, diagnostic, and treatment coverage. Harm reduction is a quite neglected area by health authorities, especially after the. In respect of diagnostic and treatment coverage, I will focus only on HCV infection for the sake of time. According to the existing data, we have diagnosed around 20% of the infected population and have treated between 2 and 3% of them. On the right side graph, you can see the number of patients treated in the last 4 years. The numbers are pretty stable after initial increase. The DAAs are the only treatment option in the country since 2016, and we don't have any restriction for treatment since 2017. This means that all health insured persons can receive reimbursed treatment. We don't have a waiting list, and we can treat as many patients as we diagnose annually. But the problem is that we do not diagnose enough patients, and this is one of the main reasons for decreasing of the treatment rates. Another problem is that there is no funding from the state for the treatment of the patient without health insurance. So these patients cannot be diagnosed.
I don't know.
Vulnerable population who are the risk populations for viral hepatitis infections are mainly without health insurance.
If you don't mind, just start at the beginning of the slide, because I don't think anything came.
Okay, good. Can I have the slide with key interventions? 2 slides before this one.
Elimination. Unfortunately, the situation with hepatitis B infection is similar to those of hepatitis C, and we are lacking behind.
Could we ask the organizers to go back 2 slides?
For hepatitis B also. So, as a summary, ladies and gentlemen,
in other direction, these are okay. Good. 2 more. 1 more. Okay, here.
Now I would like briefly to comment.
I would like to comment on these key interventions that WHO recommended to implement and to scale up in order to reach elimination. Actually, we have fulfilled the intervention in respect of vaccination
on the recommended
for
by
hepatitis B and also the safe injection.
In respect,
the previous slide, please. But 3 other areas. Okay, the next one. 3 other areas like harm reduction,
it's quite clear that infections with hepatitis C and hepatitis B represent significant health problem for the population in Bulgaria, as well as significant burden for the healthcare system. We still don't have a national plan or strategy for viral hepatitis elimination. Our national plan is actually in preparation since 2017. But it is still not finalized. And on the slide, you can see a draft from that.
Marietta, do you hear me? Tatiana is
now,
here.
I would like briefly to comment on the recommended by WHO
I think so. It is not because of you. Someone
and how
just
we are progressing on it.
Marietta, do you hear me? Tatiana is here. Do you hear me, Marietta?
Mixing of my activity and...
Marietta, we cannot.
Now it's fine.
Marietta,
okay.
We must please.
So I will go without slides.
Marietta,
I don't know if you see it, but anyway, this is one of the quite problematic area because the government is not paying enough attention to the problem, and the number of opioid substitution treatment centers remain the same, but the number of patients included on treatment decreasing because the patient should pay on their own for the treatment, and this for this vulnerable population is quite difficult. Especially challenging and especially worrying is the situation with NGOs, the low threshold centers, which are working in the area with needle and syringe exchange, and their number actually decreased by 50% or more. So this area of harm reduction, which is extremely important for eliminating viral hepatitis by preventing infection, is quite neglected in Bulgaria by health authorities. Another quite not well covered area are diagnostic and treatment rates in respect of both hepatitis B and hepatitis C. And according to the data that we have, I will focus mainly on hepatitis C for the sake of time. We have diagnosed around 20% of the infected population, and we have treated around 2 to 3% of the infected population. We have DAA as the only treatment option since year 2016, and we have removed all the restriction for treatment with DAA since the beginning of 2017. So we have all the conditions to treat as many patients as we diagnose, but the problem is that we are diagnosing quite a low number of patients, and this number is stayed quite unchanged in the last 3 years. And although the scientific society and NGOs, the patient society are very active, these numbers actually did not increase much. And we are definitely lagging behind the projected numbers that we, by the modeling studies, that we should reach in order to receive elimination. Another very important problem is that only the people who have health insurance could receive treatment in Bulgaria. So there are no state funding for those who are not health insured. And we all are quite aware that vulnerable population, which are mainly affected, and the main risk groups for viral hepatitis infection are completely uncovered. And this is issue that is quite neglected by the health authorities, although again, scientific societies and the health and patient organization are speaking quite widely about this. The situation with hepatitis B is similar, a little bit better, but still the diagnostic and treatment rates are lower. So as a summary, ladies and gentlemen, I would say that the 3 key interventions towards viral hepatitis elimination in Bulgaria are reached, but we still have struggling with harm reduction coverage, which is below the required targets and strongly neglected by the health authorities. Number of diagnosed and treated patients for both hepatitis infections remain low, regardless of universal access to diagnosis and treatment for the individuals with health insurance. No state funding exists for the diagnosis and treatment for the individuals without health insurance. And activities from the scientific and civil societies are not sufficient in order to require preventive, diagnostic, and treatment rates for viral hepatitis elimination to be reached.
Unfortunately, it's frozen.
I think we can continue, Homie.
Wonderful. Dr. Seminola, thank you so much for the talk, and thank you for your patience with the technical difficulties. We're going to turn this over now to Dr. Bujovic from Serbia, who's going to describe the year of progress in that country. Thank you so much.
Ksenia?
We have
Dear colleagues, first of all, I would like to thank you, the organizer, for the invitation to participate in this very important meeting and to present in next few minutes the current situation in Serbia regarding the treatment of viral hepatitis. The estimated prevalence of chronic hepatitis C in Serbia is about 1.13%, which means that about approximately 80,000 people have a chronic hepatitis C viral infections in Serbia. Main source of our database concerning patients who had undergone antiviral treatment still remain database of reference healthcare institution in Serbia, where the treatment and follow-up was performed. These reference centers located in big capital town Novi Sad, Belgrade, Kragujevac, and Niš. The estimated number of the patients treated so far is around 4,000 to 5,000 patients. However, considering the success rate of previous available antiviral treatment, mainly treatment with pegylated interferon and ribavirin, varying from 52 to 65%, depending on genotype and the severity of the level of fibrosis. It seems so far that we in Serbia still have high number of unrecognized, unresolved, and uncured patients with chronic hepatitis C viral infections. Considering epidemiological data, the predominant genotype infection, hepatitis C viral infection in Serbia, is still infection with genotype 1, that we recorded in more than 65% of patients, following by genotype 3 that we detected in 25% of our patients, and at the end, genotype 4 and genotype 2 in 4.5 or and 4% of our patients. Although most of our patients, more than 50%, did not have a significant degree of fibrosis, in total, more than 20% of our patients have advanced liver disease, severe fibrosis, or cirrhosis. That is the main reason occurrences of hepatocellular carcinoma is not rare, especially with observed increase of number of patients with hepatocellular carcinoma in all reference centers. Modern antiviral treatment with a drug from the group of direct antiviral agents was introduced in Serbia in 2018. Treatment is fully covered by the health insurance fund. According to valid criteria for treatment with these drugs, currently drugs from the A group can be used only in patients with cirrhosis or in special group of patients, cirrhotic patients with some kind of comorbidities, such as patients with hemodialysis, patients with some hematological disorders, or patients with co-infections with HIV or HBV viral infections. According to the initial plans of our health insurance fund, 60 patients are planned to be treated annually. However, this is so low number of the patients, and our needs are clearly mainly times greater. That is a reason that 30% more than the planned number were treated in first year. Until now, after 18 months of introductions of DA drugs in Serbia, 180 patients were treated until this day with this group of drugs, which is more than 3 years predicted number of patients. For now, only genotypic-specific drugs are available in Serbia, which means that we have available sofosbuvir, ledipasvir 3D protocol. And we also have a registered pangenotypic drugs such as Epclusa and Maviret, but they are not yet available for the treatment of patients by the payment of the health insurance fund. We hope that this year this drug will be approved for the treatment of our patients and that the criteria for treatment will be extended to the patient with milder degrees of liver fibrosis. Since 2006, immunization against hepatitis B viral infections have been mandatory in Serbia for all newborn and unvaccinated child 12 years old. These interventions significantly contribute to the reduction of the number of acute hepatitis B viral infections in Serbia. Regarding the treatment of hepatitis B, situation in Serbia is very good because we have oral analog lamivudine, that this drug was available earlier, but now the drug of choice available for treatment of our patient with hepatitis B viral infection is tenofovir disoproxil fumarate and also pegylated interferon. Although is registered for now, we don't have the possibility to use staph in treatment with our patient with hepatitis B viral infections, but actually we have increased number of patients with hepatitis B that actually need these kind of drugs, and we hope that we will soon have a possibility to treat our patient with some kind of renal impairment with hepatitis B viral infections, this new formula of tenofovir drugs. Although this started at a good, perhaps slower pace, but still forward in terms of treatment hepatitis C in Serbia, the current situation with pandemic of COVID-19 infections had significantly slowed down and postponed for some time further efforts to eliminate viral hepatitis in Serbia. In previous 3 months, all attentions and activities our health system were focused on the treatment patient with COVID SARS-19 infections. Therefore, the diagnosis and therapy of patients with other chronic infections, also chronic hepatitis, was not a priority in this previous period. Only telephone or by email consultations were performed with patients who were already in course of the treatment protocol. There was no new inclusion of therapy. However, our commission met regularly and approved therapy for our patients. Unfortunately, during the SARS-CoV-19 infections and epidemic situation in Serbia, we also had a couple of our patients with advanced liver disease, with cirrhosis and hepatocellular carcinoma with very serious and unfavorable course of the infections, primarily due to advanced liver disease, not for COVID-19 infections. We hope that by calming the epidemiological situation, our activity will again focus on further improving the treatment of patients with chronic hepatitis. We certainly plan to start treatment in the coming weeks for all patients who have been approved drugs for DA treatment, especially since they are patients with cirrhosis, and any further delay in treatment may have serious consequences for our patient and their health. Thank you for attention, and best regards from Belgrade.
Thank you very much for the very interesting talk. What we're going to do is we're running a little bit behind. Anna, please.
Mr. Razavi, maybe we have an indecent proposal for you from Zagreb. Maybe we can skip this 10 minutes pause and just go on with the panel and discussion.
Perfect.
Do you want to vote, or
so
you
we're going to
say
keep the
let's
questions.
Go?
Yeah, until the end of, after Dr. Antons gives his talk, we have a session that we can have a discussion. So if you don't mind, just write your questions down, and we're going to come back and open up for question after Antons gives a talk. Mm-hmm. So the next session is the achievement and challenges, and how far behind are we? And the COVID-19 has had a material impact on the efforts to eliminate viral hepatitis. So in fact, this is a paper that we have submitted for publication. And what we calculated is if the COVID-19 programs actually reduce the hepatitis programs, we will see about 80,000 deaths between 2020 and 2030, only because of the COVID-19 delays, actually. And if we look at incident HCC cases, globally, there would be about 50,000 excess HCC cases simply because the current programs are delayed. Now, there's no better expert than our colleague Antons from WHO, and I'm going to turn it over to him to discuss the COVID-19 and viral hepatitis elimination. Are we stepping backward? Antons, it's all yours.
Hello, good afternoon. So I haven't pre-recorded my presentation, so I hope you can see my slides now, or not.
Yes, we can.
And if I do it this way, can you see them full screen?
It's readable.
Is it full screen or?
No, it's not full screen. That's full screen.
Yeah, I'm sorry. So if I keep it like this, then can you see it better?
The previous version you had was full screen, and that worked really well.
This one.
Yeah, it's readable, so I would go ahead with it.
Okay. So good afternoon, everyone, and I'm really sorry I cannot be with all of you and cannot greet personally everyone. So and also thank you for the invitation and for giving the opportunity to give this very brief presentation to start our discussion on the impact of the COVID pandemic on viral hepatitis elimination. So first, let's recap quickly what has been happening in the last 5 months since we started to live in this new reality. So on the 1st January, just a day after China reported a cluster of very strange pneumonias related to a market in Wuhan, that on the next day, WHO activated the incidence management system. And 2 weeks later, WHO already issued the first package of technical guidance on what now we know as COVID-19, so a new threat to the global health. And according to the international health regulation, by 30, based on the information that WHO has received from the member states and also based on the monitoring of the situation, WHO declared the COVID-19 outbreak as a public health emergency of international concern, which is a very important step. And by March 11, WHO described the COVID-19 as a pandemic that was based by the observation of how many continents were already impacted by the epidemic, even though the number of cases were still relatively low by March 11, that we could see that it quickly changed, and until the end of March, or until the end of February, most of the cases were were registered in China, but as early March, we can see an explosion of cases in the WHO European region. There's the pink or whatever you call this color, and we know that many countries were affected in very short period of time. And then you see, with the evolvement of time, you can see also the other regions gradually were more and more impacted. And now we see that in the European region, the number of cases is reducing. We know some countries already declared that they have almost ended up with the epidemic. But we also need to understand that while the cases are increasing globally and other regions are becoming more and more affected, we have to be very vigilant about this public health threat, and we have to be prepared to live with the COVID for longer time until vaccine or effective treatment is available. So by now there are around 7 million cases being reported to WHO and over 400,000 deaths globally. And now we can see that the Americas, including the United States and Brazil, are the countries that report most cases and most deaths globally. So we go to the European region, that we can see that the countries have been affected in a different to a different degree, and also in the time in different period of time. So by now, as of yesterday morning, there were more than 2,290,000 confirmed cases reported to WHO, and 184,000 confirmed deaths. And of course, we know that there is always some kind of a delay with the reporting. So and also the reported number of cases is very much dependent on the testing coverage in each country. So, but what we know, that there is no country which has not been unaffected by the current pandemic. So what WHO is doing in this outbreak, and it is actually what WHO is doing in any kind of public health emergency. So it's trying to help the countries to scale up the preparedness, strengthening country readiness to respond to the outbreak. WHO also tries to assess available evidence and generate and update the technical guidance as often as possible and as soon as possible. We also try to facilitate and accelerate priority research and innovation. And also WHO has a significant role in facilitating international coordination. We know that there are challenges in those areas, but this of course remains a very key activity. And finally, WHO is also faces the challenges in communicating the risk information to all communities, and also to fight misinformation and the false news. So WHO has developed a global strategy which includes global COVID-19 preparedness and response framework with the 5 main strategic objectives, which are as follows: to mobilize all sectors and communities, to control sporadic cases and clusters, and to prevent community transmissions. And where community transmission has already occurring, countries have to suppress community transmission through context-appropriate infection prevention measures and population-level physical distancing and appropriate restrictions of non-essential travel. So also countries have to reduce the mortality by providing appropriate clinical care. And it's also very important to develop safe and effective vaccines and therapeutics. And of course, it's clear that all those measures have to be adopted according to the one of four transmission scenarios. So for that you can see on the right bottom corner of this slide. So since January, WHO has published an extensive range of technical guidance on COVID-19, including prevention control, clinical management, laboratory surveillance, essential resource planning and preparedness, and many other issues which are all freely available online, and we are trying to translate to as many languages as possible. So coming back to the topic of this session, so what are the interaction between the COVID and the liver health and the liver diseases? Of course, there will be other presentations from colleagues who are specialists in the field that they will go more into depth of this question. But it's important to understand that COVID-19 can affect liver diseases, liver patients, and liver health, both through direct impact of the disease. So some patients with chronic liver disease, with cirrhosis, and with immunosuppressive conditions are more vulnerable to the infections and more vulnerable to the risk of liver damage. But in the same time, on the other hand, the risk is coming from the adaptation or the need for adaptation of the health services to the pandemic situation. So which comes with reducing the number of face-to-face patient visits, ensuring that the medicines have available for more than 1 month, maybe delaying or postponing some investigations, but all this will come at risk. So we also have some information from our friends at World Hepatitis Alliance that recently conducted a survey of their members, so of their patient organization all around the world, on the to assess the situation, how COVID crisis has impacted civil society, delivered services, and the patients. And the main conclusions are as follows: that the pandemic has impacted the ability of most civil society organizations to deliver hepatitis-related services, which is understandable. That also the COVID-19 pandemic impacted the patients' abilities to access viral hepatitis treatments, especially in low and middle-income countries, where the health system capacity is limited. But it was interesting finding that the reluctance of people to access the services was even greater due to fear of the COVID-19 disease than the barriers or limitations of movement or closure of the services. That was the initial stage when this epidemic involved, and there were a lot of uncertainties. Now we can see that in some countries, we are already used to COVID-19, and there's less, let's say, less panic or less confusion about the pandemic. And importantly, that most respondents pointed that there was not sufficient information about COVID for people who are living with viral hepatitis in the countries provided by the authorities, and that this is what we have to work on, and this is the role of the civil society organization of WHO and also of all national partners. So here is some information about the challenges with maintaining hepatitis services that we are collecting from our partners, from other regions, from the country offices. So, and we know that the situation is different depending on the degree of lockdown, which is understandable. And we also collect the information about the continuity of treatment for IRT and for hepatitis, because IRT is perceived as a top priority for all countries, and hepatitis treatment interruptions are perceived as a less of a problem currently. And luckily also with the countries are transitioning to not back to normal, but away from the lockdowns. Also, the supplies and the provision of services are restoring. Also, another problem that the staff who was working on hepatitis was repurposed to support the COVID-19 activities in most of the countries, and Moitza was the one who acknowledged it in her presentation, and we know that in many other countries our partners or our focal points, we usually work on viral hepatitis, are currently not available because they're fully busy with responding to COVID-19 epidemic. So routine clinics have been suspended, and also testing and prevention services have been affected in many countries. But there are, of course, a number of recommended approaches how to counter those challenges. So first of all, it has been recommended to continue treatment with multi-month prescription, especially if we speak about hepatitis B, where we can prescribe tenofovir for half year or for 3 years to reduce the need for unnecessary visits of doctor, and using the telemedicine as much as possible for consultation. Consider postponing of initiation of hepatitis C treatment in the situation when there is a rapidly extending outbreak. So many countries in the Western Europe, we are already over this stage. So, but the countries which are still facing the rapidly evolving outbreak and increasing number of cases and community transmission, that would make sense to postpone what can be postponed. However, talking about the prevention harm reduction services need to be continued and adapted to reduce the risk for the staff of the services, and also to reduce the risk of the clients of those services. And also, it's important to mention that WHO encourages countries to monitor the impact of the pandemic on prevention testing and treatment by comparing the data with the same year, with the same quarter of the last year. So we have the evidence how the services have been affected, and also how the services are being restored now when more and more countries are exiting the strict lockdowns and returning to routine services. So a little bit more on the maintaining essential health services. Just a week ago, WHO has updated its guidance on maintaining essential health services, and there are specific recommendations on related to viral hepatitis services. So for the testing, it's recommended in the situation where there is risk for healthcare workers and for clients to adapt the services, to prioritize testing for high-risk individuals, and also sometimes to suspend community-based testing campaigns. But we need to understand that this should be implemented only in the time frame when there is the highest risk, when the country is transitioning towards restoration of activities. It's important to plan the catch-up campaigns and also return to normal and catch up with what has been missed during the period of lockdown. So regarding the treatment monitoring, the recommendation is to modify medicine supply and also to provide treatment for 6 months for hepatitis B, and to provide or prescribe the full course of HCV medicines for full 12 or 24-week course. And for the advanced liver disease, in this acute period of lockdowns and restrictive measures, some of the screening appointments can be postponed for a few months unless the situation is stabilized. And it's very important to plan the transition activities afterwards. Will the COVID pandemic affect hepatitis services or not? I think it depends very much on all of us and on awareness, and also on our efforts to keep the viral hepatitis elimination in focus. And with the World Hepatitis Day coming quickly in less than 2 months, I think it's a very important opportunity to emphasize the need to keep hepatitis elimination in focus, even in this new reality. And we are planning some information campaigns that will be focusing on maintenance of hepatitis services during the pandemic, and we hope for close collaborations with all of you for World Hepatitis Day and also beyond, to achieve our common goal of elimination of hepatitis. Thank you very much, and I'm happy to answer any questions, or we proceed to the discussion. Over.
Antanas, thank you very much for the wonderful talk, and I want to thank WHO for all of its efforts, not only in the region but globally, with viral hepatitis as well as COVID-19. We want to open it up to discussion now. So we have about 40 minutes that we want to have a discussion. And what I'm going to ask is if the countries, we're going to take about 5 minutes to see if there's any questions for Antons. And then we're going to go country by country and ask each individual country to report how far behind are we really, and how has COVID-19 really impacted your efforts. So we've got time for a couple of questions for Antons. Any questions for the members?
Okay, hello, Moitza speaking. If I may, do you hear me?
We do.
Yes.
Okay, thank you. Well, thank you. Well, welcome. I managed to be live here, so I didn't know if I will have time, but it's okay. So I'm very happy to hear and see you and hear from you. And Antons, thank you very much for this presentation. I mean, I'm very happy that WHO has also thought about particularly viral hepatitis. You mentioned the AASLD guidelines. Actually, EASL guidelines were prepared at the beginning of April already. And interestingly enough, this was a position paper done together with the European Society for Clinical Microbiology and Infectious Diseases. So actually together with the infectologists, with the ones that COVID is actually the infectious disease. Just now we are doing the updates because there are so many uncertainties and concerns, not only within the patients, but also within the healthcare providers, as you know. And I think we haven't said the last word yet, because just recently, as you know, it's been found that that COVID, the virus, directly infects the hepatocytes, the liver itself, and it causes cytopathic effects. So I think there's still going to be much to hear about it in the future weeks or months or whatever. So I strongly support the fact that we need to I mean, it's very important to maintain the care of patients with chronic liver disease, to prioritize and to continue our goals and our plans in the future. I think actually we should use Corona pandemic in a way of an advantage, because now we can actually go for decentralization of all this management of viral hepatitis. Many countries, as well as Slovenia, had centralized management of viral hepatitis. But now, as you know, with these COVID rules and regulations, general recommendations, it's very good that patients do not travel, do not go to specialists and so on. So I think this is time that we should use, and we should perhaps try to make like one-stop shops, the models to do as much as possible on-spot testing, treatment, awareness, and so on. So even though Slovenia is very small and we do have centralized things, we are already thinking of that. We, as I showed you, we couldn't manage to start the plans for prisons, for example, or low threshold settings. But just now we are making new plans. We'll go on spot
into the prisons, will use all the recommendations, the COVID recommendations, and will just infiltrate with our viral hepatitis plans. But on the other hand, I think that the budget of healthcare system, I think, has been exhausted in many countries due to coronavirus recommendations and guidelines and so on. So I think it's going to be difficult due to financial part as well, due to COVID, not just the organizational one, but the other part too. Thank you.
Any comments regarding continuing some of the best practices from COVID-19, the decentralization of healthcare, general population screening? Any comments regarding to that, Anton?
I fully agree with Moitz. I think we have to look what are the opportunities. It's not only challenges, and we see also from, for example, from harm reduction programs and OST, that there are some new practices. This decentralization and kind of simplification has been triggered by the COVID outbreak, and also other things as self-testing. So possibly also HCV self-testing could start in some settings, especially among high-risk groups. And I think it's important to monitor all the practices that can be good, and also maybe to document and then to try to keep what has been good and what not. From the financing, I fully agree that a lot of resources have been redirected to COVID response. But on the other hand, I think this outbreak has put the health into the focus, and many countries understood that they have been not investing enough funds into public health and also into health security and healthcare at all. So I think that could also be an opportunity if we advocate in the same time that it should not be only COVID, but also all other infectious diseases and non-infectious diseases as well. They should not be forgotten, that we might be able to put health back into focus. And I heard that also the European Commission has decided to increase the funding of healthcare. So as long as we don't miss our chance to advocate for our cause, that could be also an opportunity. Over.
Fantastic. We have time for one more question for Anton. Anyone else? What I'd like to do now is open it up for discussions for the previous speakers, as well as reports by other countries. Any questions for Professor Simonova, Professor Vince on their talk that they gave? Of course, Professor Maciej is also online as well now. Okay. Can we go through the countries and just have the countries provide reports on where they are, and are we going backward with regards to COVID-19? Anyone from Albania? Marianne, I see you on the screen. Do you want to give a quick update on Romania?
Yes, hello to all of you. Thank you, because you are invited at this meeting. You're starting with Romania, and I hope in 1-2 years to don't say Romania it's a bad example, because it's not like this. I don't agree with vaccination at newborn with the data. It's not 45, it's 85, 87, according with the National Institute official data. It's correct, it's not a lot. We want to have it 95, it will be okay. But unfortunately, it's 87. This is real data at newborn. I agree it is two different problems. First, in hepatitis C, it's good. What is happening in Romania in the last 5 years, it is good practice example, because we treated in 5 years more like 40,000 patients. and we expected a new 30,000 patients. Unfortunately, the COVID-19 situation added us a lot of problems because in the last 3 months, just a very limited number of patients starting the therapy. It's correct. It is patient who starting therapy in March or in February before the emergency situation in my country. In the last 2 weeks, the emergency situation, it was stopped, and we tried to have a new normal life. And we hope patients to have access to the therapy, because the good it is, we will treat from starting from F0. This means all the patients who are insured will have possibility to be treated. Also the children and the patient who make it in the past therapy with these new antiviral drugs. Second, with hepatitis B. Vaccination, it was a problem in this period of COVID-19, because we see as the family doctors, for example, it is family doctors who don't interrupt the vaccination scheme, but also it was family doctors who cancel it for the moment, and it was just in the last 2 months, the children, the vaccination for the children, it was restarted. I think also we must promote the vaccination from the adults, because it's really a problem in all the country with vaccination in hepatitis B from the adults. And I agree with Monica Matic. I think we must use opportunity of COVID-19, because like in Slovenia, we treat the patient with hepatitis C in 70 centers. We must to have in all the country access to the therapy, because sometimes for the patient to traveling 100 or 200 kilometers can to create problems, especially for patients with hepatitis in general and with other comorbidity. It's better that the screening program, it is stopped for it was stopped in this period, but I discussed also with a doctor with a person who are implicated in the process. All this program will restart, of course, with special condition, because we must protect ourselves, we must protect the doctor and also the patient, and it's good for us, because if you see the map, in Romania, we have, Romania have a, it was good, all the solution, what was happening in this COVID period, because our authority put a lot of restriction, but we don't have a lot of infection in COVID-19. If we have in mind a lot of Romania, from Spain, from Italy, from Germany, is turned out in our country. It's under control now. We have, today we have 145 new cases. It's okay if we see in 1 month ago. But we must to see also hepatitis is an infectious disease, and we cannot to stop it with this. We must to see in the future, to learn the lesson and to give possibility to patient to have access to the therapy, because we discuss with the patient this day, and it is a lot of patients who consider it is not was so normal to don't have some some door to have access to the therapy in this period for patients with hepatitis, and also access to the investigation, because sometimes healthy can to be don't stay in place. And I must to telling you now, I think Romania is not the bad, is not. I think Romania in the last 4 years can to be good practice example. And I saw Antons, who was present in my country in the last year. You also was, and majority of you have possibility to see the progress of the situation in Romania. I agree with you. In 2015, it was different, but now in 2020 is a little bit different. I agree with you. The strategic plan, we have adopted a strategic plan. I think, unfortunately, not working like we do to working, like we hope to working. I don't think 2040 it's a realistic time to eliminate hepatitis in Romania. But I don't agree also with 2051. It's too much. You know, I think 2045 or it's a little bit realistic and appropriate. For hepatitis C, I'm sure, because the goal point will be to testing, and to see where it is of people with hepatitis B and C, because it's real. The hepatitis B, it is from population between 14 to 55 years. Hepatitis C, it is the special population, you know, population drug users, but also population about 15 and, you know, but it's not well, because I have in my association patient with hepatitis C 41, 42 years. And it's not in special population, it's in normal population.
Oh, I think one of the things that the COVID-19 has highlighted is the deficiencies in our healthcare system. Yeah. And I'm including US in that list, actually. So to give you an example, Egypt screened 25 million hepatitis C people in 1 year. Brazil screened 7 million. Uganda, we're talking a low-income country, has screened 4.5 million people for hepatitis B. What we're seeing in North America and Europe is the fact that the countries, there's just not the political will to tackle viral hepatitis. And although, I mean, I think organizations like yours and countries are really doing the best with the resources, but the political will is not there. I mean, wouldn't it be wonderful to screen 25 million people?
But you know, Humi, what is good in Romania, starting from more like 1 year and a few months, family doctors have possibility to testing the risk person. This means all the risk person, not just a woman who are inborn, who is preparing to have a child. This is good step for us, for like the country, because before family doctor don't have this power. This is good step. Also, a lot of program, a testing program are starting from with European funds. If you see, Romania acceded in for testing in hepatitis, and AHV acceded a lot of funds, and doctors are very implicated. Civil society, this means NGO and doctors, family doctors, specialists, gastroenterologists, and infectionists working a lot in the last 2-3 years. Not just, and the collaboration between us is very good. I think this is very special from our country. We're working very, very well together to eliminate and to touch the final, you know, to see we discover the people and to give access to the therapy. Another goal it is to have access to the therapy, not just for insured population, for all the population, because I think it's not very clear for our authority. Also, non-insured population must have access to the therapy and to the investigation, because it is infectious disease. It's not just chronic disease. It's also infectious disease.
No, congratulations on all the work you have done there and the expanded access. I'm going to change over now to Slovakia because we only have about 20 minutes left. Anyone from Slovakia that can describe what's going on there?
If not...
Oh, please go ahead, please.
If there is no one from Slovakia, I'm from Bosnia and Herzegovina, if you would like to...
We would love to get an update, please.
Okay, so I'm reporting the data that we have from Bosnia and Herzegovina. We have some estimation that our prevalence rate is 1.4, which means that we might have something like 40,000 people infected with HCV. This is actually not a situation that we see in a clinical practice, because the system, how we are diagnosing and treating the patient, is something that Professor Maticic pointed out that are centralized, which should be changed in the future. I fully agree with the Professor Maticic. And we actually we are treating all the patients that are diagnosed with HCV without any national action plan that is defined. So it's in a way that who first comes, first served, which means that For the time being, we had a period of pegylated interferon and ribavirin for, let's say, 1 decade, and we were able to treat all of the patients that were infected. While introducing the DAA therapy, we did have some restrictions of the treatment. So we started first with the patients with advanced liver disease, which means with more advanced liver fibrosis and maybe some comorbidities and something like something that is making the liver disease worse. And now we are in a position that we are treating all of the diagnosed patients, which means that we do not have any more waiting list for the HCV infections, which doesn't mean that we do not have a patients. We do. According to the Public Health Institute and the reporting of the newly infected patients, we might have something like 2.5, even 4.5 like incidence rate in at least in Federation of Bosnia and Herzegovina. So we do not see those patients. We should work and start to plan the screening programs, which might involve some high-risk populations like prisoners and like people who are injecting the drugs, even though we do have the collaboration with those institutions. So we might have some more patients in the future. Situation with hepatitis B is, let's say, more stable. We have introduced the HBV vaccination, which is very good in the sense that we might eradicate the HBV in the future. It's not still like that. We have some rural areas in the country that are still very active with the intrafamiliar transmission of the disease. But since we do have available treatment, which is very efficient for the hepatitis B, we might have the solution of the problem in the near future. What was the practice that we had during the COVID infection was that we didn't perform the telemedicine, but we provided all of the diagnosed patients with the needed drugs. Patients were able to take the drugs at their home care, at their homes, and they didn't come personally for the checkout. They just sometimes send the lab findings, lab testings, and we were like that way of consulting. We were not able to diagnose too much new patients. We do not have newly diagnosed patients due to the situation that we know. So we might expect some much more patients in the future that we had in the previous situations. So let's say if we see the figures, we can be satisfied. I'm speaking about the waiting list. But if we see the figures of newly infected and reported patients, we cannot be satisfied. So a lot of things to do in the future.
Wonderful. Sounds like there's been a lot of progress there. Is there any plans for national screening for viral hepatitis?
We will not have as a national screening, but we might screen some, as I said, highly risk populations like prisoners, like drug users. We might even perform screening in the primary healthcare settings, but we do not expecting too much patients in those primary healthcare settings because they are not covering the highly risk populations.
That's helpful. Thank you so much. Can we get an update from Georgia, who's also on the call? Slovakia?
Can I speak, please?
Please.
I'm from Macedonia, from Skopje. I would like to join you and first of all to congratulate to Hepatos for the Jubilee. 20 years work is really something important, and I wish you successful work today and in the future. Let's say be healthy and strong. So I have sent my presentation, but if it's not possible to get it, I will speak something summarized data. Okay.
Perfect.
So at the beginning, I would like to mention two very important meetings held 2018 under the organization of WHO in Skopje. That were meetings about workshops about the viral hepatitis, and that was for the first time all experts in field, policymakers, social factors, NGO and other stakeholders to be gathered in one place in order to discuss the important measures and steps that should be done in order to achieve, to build a strategy and to join region and Europe in terms of elimination of hepatitis, viral hepatitis. So these were very important meetings for us. And after that, I could say that some things has been moved forward a little bit, but importantly forward. So after that, we have our Ministry of Health becoming aware about the importance of the new DAA therapy for hepatitis C, for example, has provided therapy for has provided a large donation of DAA drugs, for example, grazoprevir, elbasvir for 40 patients, and Cureva triple therapy for hepatitis C genotype 1. So that was for us a big step forward, because no one of DAA therapy are not approved for the therapy of our patients. So no one of these drugs are not still on the positive list of medication of health insurance fund. So that is paradoxically, but that is reality. So we are facing a really very, very big problem in our everyday clinical practice. The same is for new NACs, that means nucleoside analogs, which are first-line therapy for hepatitis B. So the only approved therapy for our patients, according to the health policy, is still lamivudine. So we are late in this matter, and that is a real problem, especially for us as clinicians. So we are grateful for this, that some of our patients have the opportunity to be treated with new DAA drugs. But you can imagine that some of our patients, that means category which are advanced liver disease, child C or B, and genotype 2 or 3 are not covered with this donation. So the problem remains still, and we should do everything for provide this therapy for our patients. That means lobbying at the Ministry of Health, pressure, sharing the experience in the region to compare our position with the other position. Of course, that COVID crisis became a priority for our health system, and unfortunately, the COVID crisis is still present in our country, and we are not in position to overcome this crisis, because there is a second peak of this pandemic. But we don't. We should take into account that after the COVID crisis, we should change the priorities. So do not we don't forget the other viral infections after the COVID crisis. There is another real problem in our practice, that is restricted access to diagnostic for hepatitis B and C, especially for molecular testing. So the problem is the budget. The problem is lacking of tests, not the people. We have very well educated people and very good laboratory, but the number of available tests is limited. So the access for this diagnostic is still limited. So finally, the long-term goal objective of WHO for elimination of viral hepatitis in Macedonia, it seems at the moment as a utopic idea, but we will be more. We should be more active and more more engaged in this direction. Thank you for the attention.
Dr. Ivanova, thank you so much for that description. I'm going to be, just in the interest of time, I was going to ask Dr. Rehab if they could talk about Czech Republic. And if you don't mind, we're just going to keep the comments to 4 minutes because we want to also discuss Georgia as well. Dr. Rehab?
Yes, hopefully I'll be able to join.
We can hear you. Thank you.
You can hear me. Okay, that's perfect. I'm amazed with the technology. Okay, first of all, I would like to focus mainly on hepatitis C with several notes because we were somehow stuck with COVID-19 in treatment, in new diagnosis, and so on. But nothing so horrible has happened. So, what are the outcomes, or what are the examples of approach to infectious diseases in general? Because I see talking to patients, I see talking to my colleagues, I see talking to public, I see talking to people from the insurance, they came to know that there's something very different, very important, which is infectious diseases as such. So now they are maybe more focused on what's going on when some infectious diseases is not treated properly, when it's not under control. And this is maybe one good point from COVID, if there are any good points from COVID. Let's put it this way. So maybe general awareness went up. Maybe it looks like there might be a better reimbursement from the insurance company. We were still short with the funds to treat the patients. Maybe they will speed up somehow processes to head towards the elimination of hepatitis C. Of course, even it's a long way ahead. I feel it this way. So we are thinking about the prevalence in our country, because we still feel that the figures, the data we have are not sufficient. In COVID, we are all the time, we are repeating testing. Like two weeks before the COVID has begun, I had a presentation in one place, and I was just talking only about testing and hepatitis C. I said that I can see nothing more important than testing. And they were looking at me, okay, testing, what was going on? Why testing? So now everybody knows and everybody understands what I was talking about. So we should really finalize our testing strategy. We have it ready, but we have to implement it. We have to talk to politicians and other officials to put it in effect. By the way, if we are reporting like 1,000 newly diagnosed hepatitis C in the Czech Republic a year, and we are treating 2,000 people or over 2,000 people a year. So there is some discrepancy. At least half of my colleagues are treating people who were not reported. So there are sometimes funny things to talk about. So what will be in the next? We'll see. I have no special solution, and wish you all good luck with your patients.
Thank you so much for giving us a quick description. May I turn to Dr. Glasa from Slovakia to give an update?
That's me. And I am sitting here with also Dr. Helena Glasova.
Hello.
We had some problems with micro. And also greetings to Professor Colombo. We still remember his attendance of Liver and Drugs Congress in Bratislava years and years ago. I will be not giving you any figures. If you are interested, we can send you data and so on. But just briefly, in 2018, we have a whole Congress of Hepatology Society devoted in Slovakia, devoted to the problem of elimination of liver diseases. Not only, of course, this is over-ambitious, but this was the topic. Could the liver diseases be really eliminated? Well, it's a future, and there will be a section of NASH soon coming in the program. So we are looking already there. But for hepatitis, we have a relatively good situation. We have no problems to have anybody tested who needs to be tested. This is very available. Of course, we have pockets of populations that are less easy to reach, like drug addicts and prisoners. Despite prisoners is a very special question. They are reachable, but they sometimes can say no to the testing. And so testing is not a problem. It's completely covered and really accessible to anyone. Of course, under supervision of hepatologist or infectologist or a specialist, but basically very available. The same is true for the treatment. Basically, we can treat any patient that is diagnosed and is in need of treatment according to the European guidelines. So this situation is very good. And we are sometimes surprised where are all the money coming from, because we really, at present, do not have hardship here with accessibility of treatment. So we already have treated all the cirrhotic patients we know about, and fibrosis 2-3 almost is non-existent as an active infection. And now we are getting the mild or easy cases to treat. So this is basically the situation. 2 years ago, we already drafted a national program, and this is where the hurdles are, because despite we have a very good contacts with politicians and so on, but sometimes it's not easy to sell it, though the resources needed for prevention and so on are not that terrible. And so we have, I would say, the Slovakian way. Of course, I already told you that we are going for micro-elimination in hepatitis C area, and this was an inspiration to read, and we are very much with this conception. But we have a systematic, I would say, the program on a paper, but we need more support, political support, and so on. And that's why we work very much together with two patients' organizations that Dr. Glasova represents, and I am not sure that Ivana, I'm not sure she's with us at present, and the Slovak Society of Hepatology. So we are very much working together. We do a lot of lobbying. We invite to our Congress also politicians and try our best. But I believe very much that this might be the case for European-wide effort to really make more in the public arena and to speak more and be everywhere in the television and everywhere and really win the people for that. We also did a lot of pharmacoeconomics, and we were able to show to our health insurance companies that this is a very good investment of money. So health insurance companies in Slovakia are very happy to pay. This is also a little bit surprise. Of course, there is also behind the scene lobbying for that. We are living in the real world. So you know probably what I mean. This is not done by us. but basically because of good pharmacoeconomics data and other argumentation, the situation is relatively good, but might be much, much, much more better. So thank you very much for listening to us. Greetings to all the known faces I see, and all the best for the conference. Congratulations already to our Croatian colleagues and the team that put this together. Thank you very much.
Thank you. If you don't mind, organizers, if we can just borrow 10 more minutes from the agenda, because I do want to hear from Georgia and Cyprus. Amarin, Dr. Georgieva from Georgia, would you like to make a comment about the Georgian program?
Hello, this is actually Sofia Surguladze from the NCDC. I'm Dr. Amiran's colleague. I'm an epidemiologist here. Unfortunately, Dr. Amiran at the moment is not available, as you know, due to the COVID situation in the country. He is currently at an emergency meeting, but he will be back for his presentation. But I was hoping that I could tell you a little bit about the COVID situation and how it has impacted the hepatitis C elimination program, which we are running in our country. This will be talked about more extensively in his presentation, but I would just like to give you just the general outlook of what we're dealing with. As you know, Georgia has been running a hepatitis C elimination program since 2015 onwards, and we have been scaling up screening and treatment of individuals who are HCV positive in our country, and we have been steadily going towards our goals of eliminating hepatitis C in our country. However, due to the COVID-19 pandemic, some of these processes have been hindered. In some ways, the countrywide HCV screening has declined, it cannot be denied, as well as integrated testing, which was implemented in the country a few years ago, where we integrated testing with HIV and tuberculosis on all HCV screening sites has also been reduced. Also, the follow-up identification of new cases has been halted, and linkage to treatment has also declined. However, given the fact that Georgia at the moment is dealing with COVID-19 pandemic relatively well, we like to say so. We are hoping that with time, we are able to get back on track, and we are already planning on extending our elimination strategy from the years 2021 to 2025 to make up for the lost time, but also try to find innovative ways to continue HCV elimination in the country. Thank you.
Wonderful. Thank you very much for that succinct description. Do you mind if I ask Elena or Yunalo from Cyprus to give a description of the programs in that country?
Hello?
We can hear you, yes.
Can you hear me? Yes. As you know, Cyprus is a small island, and the prevalence of HCC, it's as estimated, it's very low. And many things was done, like a microelimination, like the vaccination for the hepatitis B, for HPV. But as you know, the COVID pandemic forced us for a lockdown for a lot of months. And I just, I have just two questions for the WHO or anybody. I mean, what about if where it's now with the economy, the impact of the COVID-19 to the economy was enormous, and it's going to be in the future as well. And I was wondering whether the pharmaceutical companies will be able to reduce their prices, so more patients could be cured. And the other one, it was WHO put a goal for elimination of hepatitis C for 2030. Is it feasible because everything put on hold, and I'm not sure whether it will be feasible this target this time.
Anton, do you want to comment?
Yes, I will try. The first question on the economic impact, and I fully agree, and WHO fully agrees this is not only a public health emergency, it's also a social and economic emergency, and that's why we are strongly promoting the rebuilding the health systems and strengthening health systems. The question about the while strengthening health systems, when we are exiting from this emergency state, from the lockdowns and so on and so on. So there much more investment needs to be done in health systems, in preparedness, and also in response. The question about the prices and the policy of the manufacturers of the medicines, I think yes, it's a valid point. I'm not sure if it's a question to WHO, but I think it could be a good point for advocacy, and if the industry would like to show their solidarity and so on. That, of course, I mean, there is already a lot of price reduction has been observed in many countries, and this is also a question of how the national governments are negotiating with the private sector, and if they are building alliances between the countries for joint negotiations and so on and so on. So I think it's a valid point, but I don't know if WHO specifically can do something to influence this process faster. Yeah, apart from making alliances with patient groups and with the professional associations. And the question on the feasibility of the elimination, it's also a very good question. Of course, these targets, when they were set in 2016, we understood that these targets are aspirational, and they were based on modeling. And now we know that there are a number of countries that are on track, and maybe Homi can comment even more, because they're trying to monitor this, how the countries are succeeding in this process. But if we look at the impact of the COVID, we cannot really assess it, how long it will take and how much it will affect in the long term. Yes, because now what we can see in last few months, of course, we've seen all the services were shut or the testing was reduced, but we also need to understand that it's not over yet, and we have to look into the ways how we return to and how we resume the essential services. So I think it's a bit a rhetorical question, and nobody probably will have an answer, but I'm sure it depends on the countries themselves, how they prioritize. How they prioritize their health interventions, health priorities. But I don't think that everything will stop with this COVID pandemic. And as we discussed earlier, there are even some opportunities that we can learn from the COVID pandemic that can even support health sector in strengthening its role and focusing on health and making the governments to invest more on health preparedness and response. I don't know, maybe anybody has something to add to this, but
Okay, thank you.
Thank you, Anton. As Anton's mentioned, we're updating the list of countries that are on path to elimination, and on the website, the Polaris website, you can actually find the list. And the list that are currently on track is quite short, in fact. It's Egypt, France, Iceland, Spain, and Switzerland. Now, the list of countries that are achieve it shortly after 2030 is much longer. But we will be sending questionnaires to ask where countries are in terms of diagnosis and treatment. And we do ask to if you can respond. So those emails will actually go out next week. And we do ask that you do provide as much data as possible, and then we'll update this list. And of course, if you do provide feedback, then you will be one of the co-authors on the publications, and that will come out at the end of this year, reporting all of this data. I am going to close this session because I know we're running over time and we're about 20 minutes over. But before I do that, any last comments or questions before I close the session? Well, I'd like to thank all the speakers and everyone who contributed to this session. Thank you very much for sharing what's going on in your country. And of course, we all look forward to getting the results in a year from now and working with you to see how to make the elimination a reality. Thank you, everyone.
Thank you to all of your participants. Thank you, Mr. Razao. You were excellent. You stole another coffee break, but nevertheless, it was interesting and useful. And I hope you will cope with the rest of the day somehow.